Hi, I am Glendale A. Palacio, and today we're going to talk about T-cell deficiencies. We're going to talk about the definition, pathogenesis, clinical manifestations, diagnostic and lab procedures, treatment modalities, medical management, surgical management, nursing diagnosis, and the prognosis. So before we proceed to the discussion, let's first have a short recap about T-cell development. T-cell initially arises from a stem cell. The stem cell then differentiates into the lymphoid progenitor cell. The cell then progresses to a series of stages, at which point the cell then migrates to the thymus for maturation. This begins with double negative 1. Stages DN1 to 4 are called double negative because they express neither the CD4 nor CD8 glycoprotein. There are two glycoproteins, that is a protein with a sugar attached to it, which is used to determine if a T cell is a helper or a cytotoxic T cell. These two glycoproteins are called the CD4 and CD8. CD stands for cluster of differentiation. These are basically a bunch of markers that help differentiate one cell type from another. And finally, it will become a double positive cell. The double positive cell then goes on to become either a helper T cell or a cytotoxic T cell. The double positive cell interacts with the thymus epithelial cells, and this helps to decide whether to become a helper T cell or cytotoxic T cells. So the cells become helper T cells when it stops expressing CD8 but continues to express CD4. Conversely, the cells which become a cytotoxic T cell stop expressing CD4 and continue expressing CD8. That is why they are called the single positive cells. The rest of the development occur in the thymus, at which point the helper T cell and cytotoxic T cells then migrate into the circulation and then to the secondary lymphoid tissues. This includes the lymph node, the spleen, and mucosa-shaded lymphoid tissue. So what is T-cell deficiencies? T-cell deficiency is also called as T-cell immunodeficiencies. These deficiencies are genetic in origin. Partial T-cell immunodeficiencies constitute a heterogeneous cluster of disorders characterized by an incomplete reduction in T-cell number or activity. Unlike severe T-cell immunodeficiencies, however, partial immunodeficiencies are commonly associated with hyperimmune dysregulation, including autoimmune disorders, inflammatory diseases, and elevated IgG production. Defects in T-cell also lead to opportunistic infections. Although an increased susceptibility to infection is common, symptoms can vary considerably depending on the type of T-cell defect. So now let's talk about DiGeorge Syndrome. DiGeorge Syndrome, which is also known as 22q11.2 deletion syndrome, is a syndrome which is caused by the deletion of a small segment of chromosome 22. In the chromosome 22, a very small portion in the Q arm is deleted, and the location is known as 22q11.2. And as a result of this deletion, there is DiGeorge syndrome. DiGeorge syndrome is an inherited immunodeficiency disorder. The major facts of this disease is you have poor developed or absent thymus, so there would be a defect in T-cell production, and these patients will be immunocompromised. Severe depression of T-cell number and poor antibody responses due to lack of T-cell health patient susceptible to all types of opportunistic pathogens. These patients also undergo cardiac complications. So let us look at some of the distinct facial features of patients having DiGeorge syndrome. So as you can see, we have small low-set ears, short width of eye openings, enlarged nose tip, hooded eyes, and a relatively long face. DiGeorge syndrome is typically due to a deletion of chromosome 22q11.2. There is at least 30 genes that are affected, and one of the most important of them is the TBX1 gene. TBX1 gene is an important transcription factor which is present in the third and fourth pharyngeal pouches. And also, it is enriched in facial structures, heart, thyroid, parathyroid, and thymus. And they are also present while these tissues are developing. The DiGeorge syndrome happens when there is a heterozygous deletion at chromosomal region 22q11.2 and no TBX1 gene. So if this happens, both the thymus and parathyroid gland will be underdeveloped, which is also called as hypoplasia. T lymphocytes or T cell are important in the adaptive immune response, produced in the bone marrow and mature in thymus. So when there is thymus hypoplasia, the T cell don't mature, so there will be a deficiency in mature T cells. So this will result to having a compromised cytotoxic T cell and compromised helper T cell. And because of the parathyroid gland is also underdeveloped, also known as parathyroid hypoplasia, the parathyroid gland will secrete low levels of parathyroid hormone. And this will lead to hypocalcemia. And because of no TBX1 gene, this will also result to craniofacial malformations, such as cleft palate, underdeveloped chin, low-set ears, wide-set eyes, and a narrow groove in the upper lip. Also, impaired ears and sinus drainage. And because of this no TBX1 gene, this will also lead to abnormal conotrophus development. That will lead to having congenital heart defects. And the most common of these are the conotrungus arteriosus and the tetralogy of Fallot. These are some of the clinical manifestations of DiGeorge syndrome. The certain facial features, such as the underdeveloped chin, low-set ears, wide-set eyes, and a narrow groove in the upper lip. Heart murmur because of congenital heart defects like ventricular septal defect, delayed growth, cleft palate, cyanosis, learning disabilities, poor muscle tone, failure to gain weight, behavioral problems, recurrent infections, difficulty feeding, hypocalcemia, and hypoparathyroidism. So these are some of the laboratory and diagnostic procedures that can be used to diagnose DiGeorge syndrome. First is the array comparative genomic hybridization. This is the preferable and most appropriate test for detecting the 22q11.2 deletion. It has the added benefit of detecting large or submicroscopic chromosomal deletions or duplications on all chromosomes, in addition to the classic chromosome 22q11.2 deletion. It may also provide refinements of the breakpoints, although the size of the deletion has not yet shown any clinical correlation. Second is the fluorescent in situ hybridization. This is readily available with chromosome analysis, but smaller deletions may not be detectable. If ACGH is unaffordable or unavailable, a FISH study for the 22q11.2 deletion with a karyotype should be requested. The karyotype detects chromosome rearrangements and other chromosomal abnormalities. Third is the TBX1 gene sequencing or TBX1 deletion or duplication analysis. This is requested when ACGH does not show a deletion, yet syndrome is clinically suspected. Physical examination on the face, ears, eyes, and joints for abnormalities can also be done. Complete blood count, calcium and parathyroid hormone studies to measure the ionized serum calcium level to evaluate parathyroid function, and dilated retinal examination, because these help to detect familial exudative vitreoretinopathy. These are some of the imaging studies that can help also to diagnose DiGeorge syndrome. The radiography and magnetic resonance imaging, CT scanning, echocardiography, and angiography. So these are the treatment modalities for DiGeorge syndrome. Physical therapy to improve mobility and movement of the client. Occupational therapy to help develop practical and everyday skills. Speech therapy to improve verbal skills and articulation. Developmental therapy to help develop age-appropriate behaviors, social skills, and interpersonal skills. And lastly, immunological therapy. Medical managements for DiGeorge syndrome are antibiotics, sulfamethoxazole, and trimethoprim. This combination is used for prophylaxis. It inhibits bacterial growth by inhibiting the synthesis of dihydrofolic acid. Sulfamethoxazole and trimethoprim should be prescribed based on recommendations of an immunologist. Vitamin and mineral supplements. Hypocalcemia may occur requiring supplementation with calcium. In patients with symptoms refractory to calcium, supplementation with a vitamin D analog may also be necessary. So the first is the calcium carbonate. Calcium carbonate is used for the treatment and prevention of calcium depletion. Calcium moderates nerve and muscle performance by regulating the action potential excitation threshold. Second is the calcitriol. This agent is a vitamin D analog and the primary active metabolite of vitamin D3. Calcitriol increases calcium levels by promoting the absorption of calcium in the intestines and the retention of calcium in the kidneys. Its use should be initiated only upon an endocrinologist's recommendation. Third is the calcium gluconate. This moderates nerve and muscle performance and facilitates normal cardiac function. Lastly is the ergocalciferol, vitamin D2. This vitamin D2 analog is converted in the liver to an active intermediate and then further converted to its most active form in kidneys. Ergocalciferol effectively increases renal reabsorption of calcium, intestinal absorption of calcium, and calcium mobilization from bone to plasma. Nursing management for DiGeorge syndrome. Besides from protecting the client against acquiring infections because of weak immunity, the nurse must perform a thorough, systemic, head-to-toe assessment to the client, obtain a history of mother's pregnancy, birth history, and genetic testing. Provide counseling to the parents and monitor child's treatment progress. Provide information on the proper way of giving food. Provide good nutrition counseling. Encourage parents to have the child's hearing and vision checked regularly. Educate parents about DiGeorge syndrome and how to care for a child with the disease. And provide emotional support and motivation to the child's parents. These are some of the nursing diagnoses for DiGeorge syndrome. Self-care deficit, bathing and hygiene, dressing, feeding, toileting related to cognitive impairment. Delayed growth and development related to impaired ability to achieve developmental tasks. Impaired verbal communication related to impaired receptive or expressive skills. And risk for infection related to decreased muscle tone and weak immune system. The prognosis for DiGeorge syndrome varies widely depending largely on the nature and degree of involvement of different organs, and it is important to note that many adults do live long and productive lives. The most common cause of mortality is congenital heart defect, and the second most common is the severe immune deficiency. Mortality is higher in infancy because of the severity of these two conditions. Infants with thymus aplasia present with severe immune deficiency and typically die of sepsis caused by either bacterial or fungal infections. Thank you for watching. I hope you learned something today. Goodbye and God bless.